This is a broad overview of our activities until now. This is January to November. Let me start by giving you a quick sort of a very broad summary of what has been achieved. And we know that Shaku are here, जो इस presentation में थोड़ा और contribute कर पाएंगे. Many of you would recall in our proposal, we have put activity around Mahila Arogya Samitis in urban areas. We started with a fairly cautious engagement with the public health system because though MAs, which is the abbreviation that we use for MA, Mahila Arogya Samitis, though MAs is an important cornerstone of the public health system that was newly introduced, they existed only on paper. And most of these MAs were not activated in a form that when I say activated, they were not operational. They were only mentioned on on a document, but somehow these committees were not activated. None of the members were taken up. What we have done is to occupy this institutional space as a Sathi and really create a case for Mahila Arogya Samitis to be activated. So currently, 130 plus Mahila Arogya Samitis are reactivated in around 21 urban primary health centers in cities like Nashik, Pune, and Solapur. 750 MS members are trained. As name suggests, these are all women, and 400 plus community meetings conducted. We have a disaggregated number of how many meetings are conducted in Nashik, Pune, and Solapur. But in summary, 400 and plus community meetings were conducted in last 1 year. 100 plus local health issues identified and largely resolved. There are few issues which are directly linked to policies and which might not immediately get resolved, that's for sure, but it requires a broader advocacy, perhaps at the secretariat level. But issues that are resolvable at local level, at a municipality level, are efficiently resolved by using this platform. And most of these women who were trained by Sathi actually played a key role in resolving this issue. So public healthcare shift 355 chronic patients transition from private to public care, which includes blood pressure and diabetes care, reducing the cost. And to an extent, if you'll recall in our last call, I said there are no cheerleaders for the public health system. For private health system, there are advertising agencies, there are international agencies like McKinsey and KPMGs of the world, but public health system के लिए कोई नहीं है. So effectively, it's also boosting visibility and credibility of government services. Because another challenge that is going to come in coming few months is how public health system is able to retain some of these patients who have transitioned from private to public health care. That will be largely dependent on continued availability of medicine in a public health system. Patient empowerment, this has been one of the continued activity of Sathi. So patient literacy workshop, and we have created local forums where community or civil society organizations are able to engage with the private health setup, particularly hospital owners and charitable hospital owners. In 5 cities, we conducted meetings, and there was, in my opinion, in couple of places, it was a first of its kind of a dialogue where civil society organization directly spoke to the private sector hospitals and charity hospital owners. Sathi Helpline assisted 255 patients, and our estimation is around 34 lakh rupees were saved because we directed these patients to health schemes and charity. So when 245 patients called helpline, that doesn't mean we received only 245 calls. Every patient must have called 3 or 4 times. So effectively, until the resolution has reached. And that has been the uniqueness of this helpline. It is not a passive dissemination center. We are trying to help patients to actually get access and actually get the entitlement which they are expected to get from the government health services as well as and also the schemes, different health schemes are concerned. This is regarding Bihar, and we are working in collaboration with Jan Jagran Shakti Sangathan, and our program is SAHAR, as you know. तो इसमें 20 स्वास्थ्य साथीज जो है हमारी और 3 कोऑर्डिनेटर जो है, इनका 4 हेल्थ वर्कशॉप्स के माध्यम से अभी तक ट्रेनिंग हुआ है. बिहार और महाराष्ट्र में बहुत अंतर है. जब हमने बिहार में इंटर किया था, व्हेन वी एंटर्ड बिहार, द सिचुएशन देयर वाज एब्सोल्युटली, देयर वाज नथिंग दैट वन कुड सी व्हिच हैज अ semblance of public health system. Whatever there was an infrastructure, but in terms of functioning, the public health system was not performing at all. Today, I suppose with our inputs, our Swasthya Sathis who have been trained, one has to also take into account that these Swasthya Sathis are associated with Jan Jagran Shakti Sangathan before Sathi engaged with them. So the idioms of rights, or intuitively they know what are the entitlements. Intuitively they know the language of rights. That has been a huge benefit. So effectively, we introduced a concept of health in a community who have some understanding of what rights actually mean and how to assert right. And that has been beneficial thus far. So Swasthya Sathi is leading the way in creating change, like upholding right, questioning superstitions, and promote scientific health practices. We are trying to change a deeply entrenched history of 50 years, and you will appreciate the fact that it's not going to change in 11-month intervention. There was a exposure visit in Jharkhand in September 25, and most of these women actually traveled out of their geography फॉर द फर्स्ट टाइम इन देयर लाइफ. शकू बता सकती है कि कुछ महिलाएं ऐसी थी जिन्होंने पहली बार जिंदगी में बस में वो बैठी थी. Even able to travel in that geography is empowerment. So, coming back to Mahila Arogya Samitis, these are pictures from Maharashtra. Through MA's meetings, as I have mentioned, around 130 locality level health related issues were raised across 3 cities, that is Solapur, Pune, and Nashik. So, sanitation and water related issues, maternal and child health related issues, communicable disease control related issues, and NCDs, which probably about BP and diabetes. There were few issues about unavailability of services or late reporting by Anganwadi workers or ANM or non-availability of doctors. So health services and governance and entitlements. Entitlements primarily in the form of state government insurance scheme, where a lot of hindrances were created, where women were expected to produce a lot of documents which generally are not accessible and which are not mentioned in the scheme document itself. Some of these issues got resolved because we have trained these MAs in terms of really making them understand the basic architecture of public health services and details of health schemes. We also talk to them about their entitlements in charity hospitals and private hospitals. तो शकू, आप बता सकती है, ये भी बताइए कि इन सबका क्या क्या नाम किस लिए रखा गया.
महिला आरोग्य समिति में ही नाम डिसाइड होता है कि हमारी समिति का नाम क्या रखे, और वो समिति का फिर बैंक अकाउंट और वो नाम से समिति चलती रहती. तो ये सोलापुर का कोहिनूर महिला आरोग्य समिति है, जिन्होंने एक पेशेंट का मतलब हर मीटिंग में हम एक गवर्नमेंट हेल्थ स्कीम्स का प्रैक्टिकल डेमो लेते हैं वहां पर कि क्या कौन सा हेल्पलाइन नंबर है और उसको कैसे कांटेक्ट करना है और सर्विस कैसे अवेल करना है. तो ये जो प्रैक्टिकल डेमो किया था, तो समिति के अध्यक्ष ने अपनी बस्ती के एक पेशेंट का किडनी स्टोन का सर्जरी किया, और फिर वो समिति के अध्यक्ष और वो कोहिनूर महिला आरोग्य समिति का नाम वो बस्ती में ज्यादा मतलब माउथ पब्लिसिटी हुआ और काफी लोग वो नाम लेते रहे. जानवी महिला आरोग्य समिति जो है नासिक का, वहां पर मतलब स्लम एरिया है, एकदम झुग्गी झोपड़ी में लोग रहते, और मतलब आपको पता होगा कि पब्लिक टॉयलेट्स जो होते हैं वहां पर ऑलरेडी क्लीन नहीं होता है, पानी का शॉर्टेज है, लाइट का शॉर्टेज है, और इसके चलते एक बस्ती में जो नया पब्लिक टॉयलेट बांध रखा था, वो सिर्फ कोई नेता के चलते, मतलब उद्घाटन इनॉग्रेशन के चलते उसको बंद रखा गया था. तो ये जानवी महिला समिति में ये मुद्दा आया, और फिर इन्होंने तय किया कि चलो हम ही इसका इनॉग्रेशन कर लेंगे, उसके पहले हम वो नेता से बात कर लेंगे. तो उसका इनॉग्रेशन हुआ और वो टॉयलेट सबके लिए ओपन हुआ. एक्चुअली मतलब बताते समय इतनी छोटी सी चीज लगती है, लेकिन मॉर्निंग में वो टॉयलेट में लंबी लाइन लगाना, और वो लाइन के चलते एक टॉयलेट बंद होने के चलते दूसरे टॉयलेट पे लोड आना, और उसके हिसाब से वहां पर झगड़ा होना या काम के लिए देरी होना, ये सब चीजें वहां पर होती है। तो ये रिजॉल्व समिति ने किया। अ, उमंग का जो है, हम ही मीटिंग में बैठे थे और आया कि बस्ती थोड़ा दूर है शहर से, और यहाँ पर वो गार्बेज कलेक्ट करने वाले कॉरपोरेशन की एक गाड़ी आती है, जिसको घंटा गाड़ी बोलते हैं, जो बेल बजाते हुए आती है। तो वो गाड़ी यहाँ तक पहुंचती नहीं। तो इन्होंने निवेदन दिया और वो गाड़ी आना शुरू हो गई। इसका एक इम्पोर्टेंट चीज था जो समिति में आया कि अब हमारे बस्ती में झगड़ा नहीं होता है, क्योंकि ये घर का कचरा मेरे घर पे आता था, मेरे घर का कचरा इसके घर पे जाता था। तो इसकी वजह से बस्ती में झगड़ा होता था एक दूसरे से। तो बस्ती अभी बहुत शांत है। ये उनका इंडिकेटर था कि यहाँ पर चीजें हो गई। तो ऐसे कई सारी चीजें हैं, कई सारी समितियां हैं जो 130 समितियां बता रहे हैं, लेकिन कई सारी है जो एक्टिवली आगे बढ़ रही है।
Yeah. So this is just an illustrative example of how change looks like. So the empowerment here is visible in a form when the collectivization takes a decision about governance, and they actually go seek an explanation from political party representative, and also warn that person that if it is not possible for you to inaugurate this, we are going to inaugurate it ourselves. One good thing has happened, that MA's work has given us huge confidence in terms of how these participatory forums can be used in a form where the local issues can be resolved in a much more efficient way, rather than going for a very broad advocacy. Mobilizing people for solving local issues through local advocacy is something that we are rediscovering. This is one story which, in my opinion, is very interesting and very encouraging. Shaku.
हाँ, तो ये समिति की ही सदस्य थी। इनको एंजियोग्राफी, हार्ट अटैक आया, एंजियोग्राफी हुआ और एंजियोप्लास्टी के लिए कहा गया। गरीब महिला, बस्ती की रहने वाली। तो पॉसिबल ही नहीं था कि 1.5-2 लाख रुपए एनजीओ प्लास्टिक के लिए दे या कर्जा उठाए, या गवर्नमेंट में उतना फास्ट सर्विस नहीं होता है। तो एमजेपी जो है, महात्मा ज्योतिबा फुले जन आरोग्य योजना, ये स्टेट का स्कीम है जो 5 लाख तक इंश्योरेंस देता है। और महाराष्ट्र के जो रेसिडेंट्स है उनके लिए ये स्कीम्स है, महाराष्ट्र स्टेट का। तो कमलताई, ये जो ग्रीन साड़ी में दिख रही, वो हमारी फील्ड फैसिलिटेटर है नासिक की। तो उनको फोन आया कि भैया समिति का सदस्य है, क्या करे। तो कमलताई ने बोला कि चलो जल्दी से महात्मा ज्योतिबा फुले में उसका एडमिशन कर दे और वो हो जाएगा। तो महात्मा ज्योतिबा फुले जो स्कीम हम अवेल करते हैं, उसके लिए कुछ डॉक्यूमेंट्स लगते हैं, और एक इम्पोर्टेंट डॉक्यूमेंट है रेशन कार्ड। और ये ताई के पास रेशन कार्ड नहीं था। तो फिर क्या करे, तो वो फूड डिस्ट्रीब्यूशन ऑफिसर जो रहते हैं उनके पास गए। वहां से उन्होंने सर्टिफिकेट लिया, और सर्टिफिकेट्स के चलते उनको 1.45 लाख का स्कीम्स अवेल हुआ, और उनका एंजियोप्लास्टी हुआ। एंजियोप्लास्टी होने के बाद ये जो ताई थी एकदम खुश। दूसरे दिन ही डिस्चार्ज हुआ, प्राइवेट अस्पताल में हुआ। गरीब महिला कभी भी ये इतने बड़े प्राइवेट अस्पताल में नहीं जा पाती, लेकिन ये सब स्कीम के चलते इम्पैनल किए गए हैं कुछ प्राइवेट अस्पताल। दिवाली में ये दीदी ने कमल ताई को फोन किया और बोला कि आइए हमारे घर। तो कमलताई ने थोड़ा इनकार कर दिया कि चलो, ये तो यार कार्यकर्ता का काम ही है और करते रहना है। तो ये और उनका बेटा कमलताई के घर आए और उनको साड़ी गिफ्ट दिए और स्वीट्स दिए, और कहा कि सिर्फ आपकी वजह से मैं ये दिवाली देख पा रही हूँ। से एक्चुअली जिस तरीके से लोग ये उपकार भावना में जा रहे, वो कहना भी अच्छा नहीं लगता, क्योंकि ये राइट है और ये सबको पता होना चाहिए। लेकिन ये पता ही नहीं है लोगों को। 5 लाख का स्कीम किया है, लेकिन लोगों को एक मतलब थोड़ा सा सर्वे भी किया, थोड़ा मतलब डिग भी किया, तो समझ में नहीं आएगा कि क्या चल रहा है, और लोगों को क्या कुछ पता नहीं।
काफी दिनों से यहाँ पे मसला था, तो वहीं का ये एक फोटोग्राफ भी आपको दिखाई देगा। आप बताइए शकु।
मुस्लिम बस्ती है मुख्य तौर पर। और आंगनवाड़ी ताई, जो आंगनवाड़ी हर रोज 10 बजे खुलनी चाहिए, 10 से 2 बजे तक बच्चे रहते हैं, 4 बजे तक आंगनवाड़ी सेविका, टीचर एंड मददनीस, हेल्पर, वो 4 बजे तक रहती है। लेकिन 2 महीने से आंगनवाड़ी बंद है। तो इन्होंने हमने कहा कि जाइए बात कीजिए, तो वो आती ही नहीं। तो क्या करती है, तो वो कहती है कि हम सर्वे कर रहे हैं, टाइम नहीं है आंगनवाड़ी खोलने में। आंगनवाड़ी नहीं खुलती है तो बच्चे को खाना भी नहीं मिलता है वहां पर। जो न्यूट्रिशियस जो भी फूड मिलता है, दाल खिचड़ी हो या चना हो या स्प्राउट वाला जो है, वो मिलता है, लेकिन वो नहीं मिल पाता था और बच्चे यहाँ वहां घूमते। गरीब घर के बच्चे वो प्राइवेट स्कूल में नहीं जाते। तो फिर हमने यही मीटिंग में, ये वही मीटिंग का फोटो है, यही मीटिंग में हमने नंबर लिया और आंगनवाड़ी ताई को, दीदी को फोन किया। तो उसने कहा कि हम सर्वे कर रहे हैं, अध्यक्ष ने, और हमने पूछा कि ऐसा कौन सा सर्वे है कि जो 2 महीने तक आंगनवाड़ी बंद है। और फिर वो थोड़ा डर गई, और फिर एकदम शांति से हमने कहा कि अगर कल से आंगनवाड़ी नहीं खुलेगी तो हम आगे आपका कंप्लेंट कर देंगे। और दूसरे दिन सुबह एकदम प्रॉपर 10 बजे आंगनवाड़ी खुली। ये सब महिलाएं वहां पर गई, आंगनवाड़ी दीदी के साथ बातचीत, और उसके बाद वो खुलने लगी।
Transfer of health officials and medical officers in the health department is a norm, but it used to occur with certain frequency previously, say around 4 or 5 years back. Currently, I mean, once the person is appointed, he or she is used to work in a particular one place for, say, around 1 year or 2 year. Now that span has reduced a lot. So some of these medical officers are transferred, say, in 8 months, 9 months, even in 6 months. And some of these officials are at the higher level. And that leads to a poor institutional memory. What happens that once we have advocated with the municipal commissioner that this is a MS model which has been reasonably successful, for example, in Nasik, next thing we hear that that person has passed the order, but he has been now transferred. So there's a new person with whom we have to renegotiate everything. And then it all goes back to the sort of whether the new officer who is coming at that place is pro people, is well-meaning, so on and so forth. And that is creating sort of a issue for us with this poor institutional memory. NCD medicines shortage in urban PSCs and health and wellness center is known. Usually, none of these PSCs are receiving a stock of more than 15 days. When the real thing is, it is expected that they should have a stock of at least 2 months. And people don't have a time to go back to public health system and again for taking a medicine for a chronic disease. They expect that if I'm visiting your clinic, give me medicine at least for a month. So that is one issue that we are trying to tackle. Bank account opening, which is a very important thing for MS members, that has been not going on too smoothly because banks are demanding ridiculous amount of documentation when these MS members are going to open the account. There's no coordination. I mean, what we generally speak about intersectoral coordination, but if government order is to MAs to open a bank account, bank has no business actually to stop that. But they do that on a regular basis, demanding, आज ये document नहीं है, वो document नहीं है, आपको ये लाना पड़ेगा. Effectively, not allowing the MS members to open the account. And one of the signs that MS is now active is to have a bank account because then it makes it legitimate. So dates for field level programs and workshop is a major challenge as dates often need to be changed due to factors like strikes, elections, weather conditions. This time the monsoon, as you know, was fairly bad. Maharashtra is undergoing, currently we are in an election phase. Most of our municipal corporations are going to go for elections in the first week of December. Glimpses of all the things that we are doing and each photograph here has a story, but for lack of time, I really don't want to go in this interesting conversation. Maybe we should have only a session where we will be able to share these very encouraging stories. But just to, and Shaku might be able to add one thing, just to comment on this particular photograph, where doctor is, इसके बारे में बताइए. केवल इस फोटोग्राफ के बारे में।
हाँ, ये नासिक का इंदिरा गांधी रुग्ण हॉस्पिटल है, जो वहां पर मेजोरिटी विमेन हॉस्पिटल कहलाया जाता है वहां पर। डिलीवरी एंड एएनसी केयर एंड सिजेरियन सेक्शन भी वहां पर है। ये जो डॉक्टर है वहाँ के एमए से मेडिकल सुपरिटेंडेंट, और महिला आरोग्य समिति का जब वर्कशॉप चल रहा था, ऑफ कोर्स ये इनवाइटेड थे, उनके ही हॉल में हम उन्होंने ही जगह दी थी कि यहाँ पर वर्कशॉप कीजिएगा। हर एक महिला आरोग्य समिति से करीबन 5 लोग हमने इनवाइट किए थे, तो कई जगह 5 से 7 आ गए। और इतने कम्युनिटी लेवल के लोग आ रहे हैं, अपनी बात रख रहे हैं, इतने धड़ल्ले से इश्यूज रख रहे हैं, कोई डर नहीं रहा, तो उनको बहुत खुशी हुई। वो जस्ट आए थे देखने की क्या चल रहा है, लेकिन उन्होंने एकदम से फोन कॉल करके उनके पीए को बताया कि फूल लेकर आओ, और सब समिति का उन्होंने सत्कार किया, फेलिसिटेट किया वहां पर सबको एकदम आगे बुलाकर।
Yeah. So this is a rare instance where people from whom we are seeking accountability have felicitated our representatives. So patient support cell engagement with the private health sector, which has been sort of our program for now a couple of years. So there were total 6 sessions organized between February to August 25 on patients' rights and grievance redressal in different cities. And patient forums are now established in Nashik, Ratnagiri, Kudal, and Chippur. Nashik is in North Maharashtra, Ratnagiri, Kudal, and Chippur are in Konkan area, where we had a very good meeting where civil society organizations and few private practitioners participated. What impact we have achieved? 48 hospitals audited for compliance with Patients' Right Charter and transparency standards. Interestingly, there are 2 charters which are now floating around. One is a National Accreditation Board of Hospitals, NABH. So it's a private entity. This NABH accreditation is important for private hospitals. NABH has issued their own patients charter, but it is so watered down and it has completely neglected some key patients' rights related issues in their charter, because they work in very closely in collaboration with private hospitals. Obviously, they were not too comfortable, in my opinion, about the rights language, which generally is included in National Human Rights Commission patient charter, which is subsequently ratified by the Health Ministry. So they are not using Health Ministry's patient charter, but NABH is actually pushing for patients' right charter that they have created. So most of the hospitals now are legitimately claiming that we have displayed patients' right charter, but it is not the central government charter, but this NABH charter. So that's an additional sort of a complication where we have to tell them that this is not actually the charter that we expect you to display. The charter that we are saying is government charter, and that's what is actually a legitimate charter which every hospital should display. So that's another fight which is now going on. So there are constructive dialogues with Indian Medical Association, Hospital Owners Association, NIMA is National Integrated Medical Association, which is Association for Ayurvedic Doctors, to encourage the compliance with this patient's right charter. And our advocacy led to the reactivation of toll-free grievance redressal number. And currently we are doing a lot of follow-up meetings with officials in Ratnagiri. So this toll-free grievance redressal number in Nashik is now alive. It went live. And we do expect in next 6 to 7 months post-elections, probably we might be successful in actually starting this grievance redressal number in various other cities of Maharashtra. Of course, it also depends on how much interest local officials take and how much our advocacy is going to be successful. So challenges, obviously there is a resistance from private hospitals. Many hospitals are reluctant, especially regarding rate chart. They cite a lot of procedural burdens and, we have already displayed NABH charter, why you are imposing this another charter on us, so on and so forth. So, and there's also a limited enforcement by public officials. So regulatory architecture, as far as private health sector is concerned, is very weak. Traditionally, it has been weak. And one of the reason that the local authorities who are expected to monitor and regulate the private or establishments, they are not doing their duties as expected. Or rather, in some places, they are not doing any duty at all. So that's the big problem. Many government officials surprisingly lack understanding and motivation to implement patients' rights provisions. There are many places where municipal corporation people, local authorities request साथी कि आप आइए और हमको बताइए इसमें कैसे मॉनिटर करना है. And which is ironical, the people who are expected to regulate and oversee the compliance, they are not competent enough to really see what private hospitals are expected to provide, how they are expected to provide, what are the compliances issue that they need to observe. So it's a bit of a chaotic situation. There's a confusion over regulations. As I mentioned, the ambiguity between NABH and patient MNHRA patient charter. Some cities like Nasik benefit from proactive officials. Everywhere else, only strong social mobilization overcomes bureaucratic reluctance. That's now our conclusion. So we will collaborate and cooperate wherever there are proactive and pro people officials exist with. We will resist and we will go for a social mobilization where the system is not responding to this advocacy agenda. So sustaining mobilization, I think with these meetings that have taken place in different places in Maharashtra, there's a lot of interest. A lot of media coverage also occurred of some of these workshops that we conducted in cities of Maharashtra. So this is all about the private sector related interactions we had in the state of Maharashtra. You will see photographs from Chiplun, then Pune, then
Solapur,
Solapur, and then
Mumbai,
Mumbai, and
Kuda,
Kudal. Kudal is
Nasik.
in Konkan, and then Nasik.
एक्चुअली हम पेशेंट,
Arogya.
हाँ, पेशेंट सपोर्ट्स हेल्पलाइन एक चला रहे हैं जनवरी से। और धनंजय ने पहले जो बताया था कि एक्चुअली पेशेंट सपोर्ट हेल्पलाइन सिर्फ कॉल रिसीव करना और उनको गाइड करना नहीं, लेकिन उनको लास्ट तक बेनिफिट मिलना है, इसके लिए हम फॉलो अप करते हैं और टेलीफोनिकली गाइड भी करते हैं कि आपको अगर उसमें से कुछ बेनिफिट लेना है तो आप क्या करना है, कैसे अगर कोई दिक्कत आती है तो हॉस्पिटल के साथ भी बात करना, ये सब हेल्पलाइन से हम करते हैं। अभी तक 248 कॉल्स हमने रिसीव किए हैं। इसमें जो बहुत सारे कॉल्स आते हैं कि हमको स्कीम्स के बारे में पता नहीं है, अगर हॉस्पिटल में एडमिशन नहीं होता है तो क्या करना चाहिए। ट्रस्ट हॉस्पिटल्स जो है, तो बहुत सारे हॉस्पिटल्स डिनाई करते हैं कि ट्रस्ट का जो फंड है वो अभी हमारे पास नहीं, वो खत्म हो गए हैं, तो आप दूसरे हॉस्पिटल में जाइए। तो इसके बारे में हॉस्पिटल के साथ बात करना, पेशेंट को एक मोटिवेट करना कि आप उनके साथ कुछ रिटर्न डायलॉग कर दीजिए, इसके बारे में हेल्पलाइन से बता देते हैं। अभी तक हमने 47 लाख का अभी सेविंग्स, हमने जो हमारे पास अभी जो कैलकुलेशन है वो है। बहुत सारे कैलकुलेशन से भी लोगों ने बताया नहीं कि उनको क्या क्या अभी सर्विसेज मिले हैं। दूसरा ये भी है कि हम जहां पर वर्कशॉप्स लेते हैं तो वहां से बहुत सारे कॉल्स आते हैं। अभी पुणे सिटी में इसका बहुत सारा ये रहा है कि लोग पूछते हैं कि अगर ट्रीटमेंट लेनी है, फ्री में ट्रीटमेंट लेनी है तो कहाँ से ले सकते हैं, एमजेपी जो ऐसी ट्रीटमेंट लेनी है तो डॉक्यूमेंट की जरूरत क्या होती है, तो ये सब हेल्पलाइन से भी चल रहा है।
These are some of the testimonies. We have a lot more such testimonies where patients have proactively approached us, and it's a very emotional experience when people talk to you. Some of them just break down. Some of them, because spending 7 lakh rupees or even 1 lakh rupee for from a poor family, it's an intra or rather intergenerational indebtedness. A auto person may not be able to repay that kind of a loan in his lifetime. So this kind of lot of stories are now accumulating within Sathi. We are planning to publish it, obviously with due consent, and wherever required, we will maintain that anonymity. Coming to बिहार, बिहार में कैपेसिटी बिल्डिंग वर्कशॉप अभी तक 4 हुई है और एक एक्सपोजर विजिट हुआ है जनचेतना मंच में। 20 स्वास्थ्य साथीज और जो 3 वहां के समन्वयक है, 3 कोऑर्डिनेटर्स, वी they have undergone all the 4 capacity building workshops, and mainly issues that we covered are reproductive, maternal, child health, menstrual hygiene, scientific temper, TB, HIV. So we started with a bare minimum of at least making people what we call as a body literacy before entering into pathology and disease and medicine and so on and so forth. Most of these capacity building workshops were tailored based on the what we observed there and what kind of inputs are actually required. Now, Swasthya Sathis are now conducting hamlet level meetings. They visit health and wellness center. They are coordinating with ashas, and also they are discouraging quack practices, which was very rampant in that area. And coordinators have begun lodging written complaints on service denial and, for example, even lodging a complaint against unsafe drinking water during monsoon. I will definitely say there's an upward trend in terms of how Swasthya Sathis have progressed. We started with a fairly modest expectation and a cautious line that Bihar was new even to Sathi. But way things have unfolded in Bihar, I think we are fairly optimistic that a lot of good things will come out of this model, including perhaps at one point in next 2 years go for a broader advocacy of generalization of model like this.
इसके कुछ खासियत बोल सकते हैं या मुख्य मुद्दे ये है कि ये कम्युनिटी जो है जिनके साथ अपन काम कर रहे हैं, आप सबको पता होगा जन जागरण शक्ति संगठन के साथ काम हो रहा है, लेकिन संगठन के मुख्य तौर पर जो इलाके हैं गांव के, ये दलित, महादलित, मुसहर, ऋषिदेव कम्युनिटी से हैं, जो इंडिया में एकदम दलित तबके में भी और वो हायरार्की में और निचला समझा जाता है। दूसरा, बहुत गरीब लोग हैं, ये वर्किंग क्लास है, नरेगा का काम मिलता है तभी कुछ आगे बढ़ता है, या तो मजदूरी। मेजॉरिटी घरों में लोग माइग्रेंट हुए हैं, जो पुरुष है इन घरों के। अगर शोहिनी यहाँ पर है तो वो भी जोड़ सकते हैं या ये मुद्दा आगे बढ़ा सकते हैं। एक्चुअली काफी चैलेंजिंग है यहाँ पर काम करना। एक तो शुरुआत ही है कि जो हमारे साथी हैं परिस्थिति के चलते कभी स्कूल नहीं जा पाए, ऐसे 50% से ज्यादा साथी है। जो 20 है उसमें से आधे से ज्यादा है जो लिखाई पढ़ाई नहीं जानते। यहाँ पर एक मुद्दा है कि यहाँ पर फ्री हेल्थ सर्विसेज है, पब्लिक हेल्थ सर्विसेज, लेकिन वो नाम के लिए फ्री है। एम्बुलेंस ड्राइवर से लेकर वो जो हॉस्पिटल में हेल्पर रहती है वहां से लेकर बड़े डॉक्टर तक सब जगह करप्शन है, 100 रुपये से 1000 रुपये तक। तो ये इसको हमने पहली शुरुआत में चैलेंज किया, और जो पहली तस्वीर में दिख रहा है कि पहला जो फोटो है ये 10 रुपए का केस पेपर कटा रहे थे, और जब पता चला कि नहीं भैया 2 रुपये या 5 रुपए लगते, तब जाकर पता चला कि वो जो हेल्थ प्रोवाइडर वो हेल्थ एंड वेलनेस सेंटर में आ रहे हैं, वो उनका जो ट्रैवल एक्सपेंसेस है वो भी ये केस पेपर में लगा है। तब ये हमारी मुन्नी दी है और उसके साथ 6-7 महिलाएं चली गई और वहां पर एकदम डिमांड की, लड़ाई झगड़ा किया और 5 रुपए केस पेपर किया। तो घूस वाली चीज जो है ये शुरुआत में लोगों ने हाथ में ली कि कहीं भी जाओ, कितना भी सीरियस पेशेंट हो, 1 रुपया भी नहीं देंगे। दूसरा, झोला, झोला छाप बहुत है और ओझा भी बहुत है।
शामन्स,
हाँ,
जो मांत्रिक होते हैं वहां पे,
कम्युनिटी उसकी शिकार है, और झोला वहां पर अवेलेबल है। कोई भी बीमारी हो, चलो सलाइन लगाता है, 300-400 रुपए लेता है। तो ये जो 3 चीजें हैं, कहीं पर भी पैसा न देना, झोला के पास नहीं जाना और ओझा के पास नहीं जाना, तो ये 3 चीजों पर अभी पहले 8-10 महीने में शुरुआत की, और साथ ही एक एक कदम आगे बढ़ रहे हैं। तो ये मतलब उनके लिए अस्पताल जाना, हॉस्पिटल से डॉक्टर से बात करना, आंगनवाड़ी विजिट करना, ये एक एक सीढ़ी का कदम आगे बढ़ाने वाली चीज हो रही है। काफी सारी स्टोरीज है यहाँ पर। ये रेखा देवी की स्टोरी है, जो लेफ्ट साइड में छोटी जो बच्चे को लेकर रुकी, वो समता कुमारी है, और 21 साल की पहला प्राइमी है, और पहला डिलीवरी के लिए, और जो बीच में पिंक कलर की साड़ी वो हमारी स्वास्थ्य साथी है रेखा दी, सहरसा डिस्ट्रिक्ट से है। अगेन वही दलित कम्युनिटी, गरीब, एक नॉर्मल डिलीवरी के लिए उनको 4 अस्पताल घूमना पड़ा और डिले हो गया, फिर भी उन्होंने कैसे तैसे करके नॉर्मल डिलीवरी रेखा दी की। ये बहुत लंबी स्टोरी, हमने बहुत कट शॉर्ट कर दी है।
Most of these things are already mentioned, the kind of challenges that we are witnessing in the state of Bihar. So these are some photographic glimpses of what we are trying to do in the state of Bihar. Coming to the last section of today's presentation, as you know, part of this AID support we were also using for creating innovative videos and stories, what we call as a SATHI Health Communication and Narrative Lab. There were 7 short video stories that we have published in last 6-7 months. After these stories were actually publicized, there were quite a few journalists and ordinary people who contacted us. They said that they are understanding the complexity of this issue for the first time, though they have been staying in the state of Maharashtra for years together. So in a way, visualizing some of these issues is one of the objective, and I think if not very successful, I'll definitely say there is general positive trajectory in terms of increasing the viewership of some of our videos. And in the same context, last month we also had a sort of we just published this booklet, which is really becoming popular. This is 12 photographs of women, and which includes a very short description of their stories, not more than 50 to 60 words in Marathi. But it effectively tells about the society that they are living in, their expectation not just from the husband, but their family, their community, elected representatives, public health system. This is effectively a collage of these ignored voices. They are from the extremely remote corners of Maharashtra where we went in search of these stories. And after actually documenting these stories, I've realized one very important thing, that real aspirations of people are not known through a focus group discussion. You need to have an informal channel of communication. Sit down, listen to them, whatever they are trying to say, in a way that they really feel comfortable. We managed to elicit this story through those informal, हम गए हैं और हमने उनसे बात की है, because they are clever enough to know कि ये लोग कहाँ से शहर से आए हैं, ये क्या 2 मिनट के लिए रुकेंगे और निकल जाएंगे. So making them comfortable, making them understand why we are doing this was also a sort of a important strategy in when we did that. Now, this photograph where you see an exhibition, last month we had an exhibition in Pune, in Yashwantrao Chauhan Natyagriha Kaladalan, which is an art gallery, where we have put in around 68 photographs that we have collected from the community. Some of these photographs were from the Mahila Arogya Samitis of Pune, Nasik and Solapur area. And the overall idea was,
Ratnagiri,
Nandurbar, Amravati, Ratnagiri, so a lot of places. And the idea here was to also invite some of these women whose stories are actually displayed. And we wanted to tell them that this is your story. This is your story of resilience and it matters. Everybody wants to hear that. To say the least, it was very emotional experience for everyone, because for the first time, many of these women were seeing themselves. They really thought that what they lived every day, there's a resilience, and it's important, and a lot of people actually consider their effort of survival as something that is worth depicting and telling others. So a lot of informal conversations, and the entire program was led by these women. They spoke in whatever way they wanted to do that. But effectively, in 2 days, I suppose, how many people saw this exhibition in Pune city?
300 to 400.
Around 400 people came to see this. Typically urban middle class people, and there is a lot of sort of input and feedback that we have got from them, that this is a remarkable exhibition that has ever been hosted in a place like this. So I think this as a strategy we will be continuing even in future. Dhanyawad, thank you for bearing us for 22 slides, which is perhaps But believe me, this is an abbreviated presentation. Initially, we thought the total number of slides were more than 35. So, thank you so much.